Welcome. I'm Laura Finkelstein, and I'm a member of the pediatric group. We practice at University of Maryland Pediatrics at Midtown, which is right across the street. And I'm one of the general pediatricians in that primary care practice, and I am part of the University of Maryland School of Medicine's Department of Pediatrics as well. If anybody is interested in more information about our practice and about the clinic as we go through this, there is a person, Kevin White, who is our clinic manager, who's in the back there, who can make appointments for people if they want to do it on their way out the door. If not, you'll get information about phone calls and things like that. I'm going to start moving relatively quickly because I want to make sure that you have time for any questions at the end of my presentation. If I go too fast, just wave wildly and let me know and I'll slow down, and we'll take it from there. So I guess without further delay, we'll go ahead and get started. You want to help? Please? Okay, so we can do that. Alrighty, so the purpose of my talk today and sort of what I'm going to try to go through is to talk about the recommended vaccines that are currently provided for children, and I'm not really going to touch on the adult ones today because that's beyond the scope of my practice. And I'm going to talk about the diseases that they were designed to prevent, and also touch on some of the recent controversies and issues relating to childhood vaccines that you may have heard about. And obviously, people have questions at the end, you'll be able to ask those too. So to start out, the history of immunizations, a lot of people don't realize that we didn't start doing vaccines in the 20th century. Okay, people think so. But in fact, the first written vaccinations were done in 1022, actually. And it was by a Buddhist nun who was introducing smallpox scabbing to patients to prevent smallpox. So to try to give a milder version of the disease. And then that same technique was introduced by a English woman in 1721. That technique was brought to the West. So this is a really long-standing tradition. It's not really all that new. The more modern era of immunizations was thought of as beginning with Edward Jenner, who was a physician who noted that milkmaids who were working with the cattle who got cowpox, which was an infection of cows, actually didn't get smallpox, which was something that was very prevalent and quite a killer at the time. And so he decided to try giving cowpox to several test subjects, including his own son, with this infectious material, and developed the first vaccine, which was Vaccinia, which is the cowpox vaccine. And actually that was used in purified form in slightly more controlled manner than he did. But that was in common usage until 1980, when smallpox was eradicated worldwide. And we no longer need to use that vaccine. But the oldest vaccine that is considered modern is quite old. So they're not new. The concept isn't new. The types of vaccines that we use, and just this is background information for the rest of my talk, there are what are called killed vaccines, which means that the product can't cause an infection. It can't turn into whatever the disease is in your body. There's no way to do that. It is completely dead. There are live vaccines that are a version of the infectious agent that are weakened so they can't cause a serious infection but can provide protection. And then there's a toxoid vaccine, which is actually not an infectious particle at all. It's actually made from something that the bacteria, in most cases, or virus would create that causes the problem. And the vaccine actually protects against this toxin rather than against the agent itself. And we'll talk about those too. So just some background information. And the way vaccines work in general is that this agent, this protein, is introduced into the body, and your body has an immune response. And you can see sort of a model here. Here's what the vaccine going in. And you get a little bit of reaction here, and then these are antibodies which are designed to protect the body when it sees the natural agent come in. So to provide you sort of a heads up early warning system to fight off the infection. So that's kind of the basic premise. This is the current recommendations for vaccinations for children from birth through 6 years. There is one There is a set of vaccines that is given later than this in the teenage years, but I gave you this as an example. And we do have this also on a handout for you in the back if you want it. And some information about links to other information from the CDC. So talking about the diseases now, because this is really why we do this. Starting with hepatitis B, and because it wouldn't be a complete talk without something silly, here's the "you've got hepatitis B" slide. Don't know why, I just felt like it. So the virus is actually transmitted directly person to person by what we call intimate contact. And she's probably too young to understand what I'm talking about, but I'm not going to go into too much detail with baby in the room. But it is a blood and body fluid contact, and it can be transmitted from an infected mother to the baby. And it can cause inflammation and damage to the liver, which can cause a chronic infection, which leads to liver scarring, called cirrhosis, liver failure, and liver cancer. And that's a picture of somebody with chronic hepatitis B with cirrhosis and liver cancer. That's what is the end point of this. And younger children are more likely to go chronic than adults. So when a child gets exposed to hepatitis B as an organism, they are more likely to go on to the pathway that leads to this. So that's something that we really want to prevent. Hepatitis B accounts for about 1 million deaths worldwide each year, and about 350 million people in the world are carriers chronically of this disease. So it is nowhere near gone. Now this is a slide from the World Health Organization, and this is actually a little bit old. It's from 2005. The United States is a low prevalence area because we vaccinate. Places in sub-Saharan Africa, much higher. Asia, much higher. Actually, up here in Alaska doesn't do so well, interestingly. And the northern parts of Canada as well, there's a fair amount of hepatitis B. So, and the orange areas are the ones where we're kind of in between. So we're not done with this one, it's still around. The vaccine is actually laboratory created. You cannot catch Hep B from the vaccine. And that is a change. The history of the vaccine for this particular disease used to be a blood product. They got rid of that when HIV was identified because you didn't want the risk of that agent coming along for the ride. So this is actually a very safe vaccine and has been used for better than 20 years at this point. It's really, really effective. So looking at hepatitis B, the top line here is adolescents, is teenagers in the United States, and this is the rate of acute hepatitis B, so the immediate infection in children between 1990 and 2002. And you can see this in lovely trajectory of straight down with the teenagers. Here's where the vaccine was introduced. Okay, so it's a nice trend. It seems to be doing something. We're not seeing the infections anymore as in kids as they go. These bottom lines are the younger kids. And those also you see decreasing almost to zero with vaccination. So we're really doing a nice job here. And some of these kids, the ones from 2002, it's because they were infected from transmission from their parent before the vaccine was introduced for the mom. So you have some transition time. But it's been a really effective vaccination. Diphtheria. People don't talk about this anymore because we really don't see it. It's actually a bacterial infection with, that causes this very thick membrane that coats the back of the throat. When someone gets diphtheria, the case fatality rate, meaning your odds of dying if you get diphtheria, is 5 to 10%. Okay? And with higher death rates, up to 20% in kids under age 5, which is my population that I take care of, and then older than age 40. So when you get into the more seasoned adults, and I'm over 40, so I can say that, and the kids under 5, it's a really dangerous disease. And even with modern medicine, the fatality rate when someone gets this has not changed very much in 50 years. So we have better medicine and better medical care. It doesn't seem to make a huge difference with this. And the complications of this disease are not actually caused by the infection per se, but by a toxin that the bacteria produces that causes the membrane to form. So the vaccine is one of those what I call toxoid vaccines, meaning it's a vaccine against that toxin, not against the infection. So there's nothing out there stopping any one of us from catching diphtheria. We're just not going to get sick, okay? And so we could be walking around with the diphtheria in our throat. It wouldn't be causing us any problem, but we could give it to someone else, okay? Because we're protected against that toxin, that poison that the bacteria is making, not against catching the bacteria. The vaccine was introduced in 1923, so it's substantially older than most people in this room, I think. And in 1921, before the vaccine was introduced, there were more than 200,000 cases in the United States, accounting for 15,000 deaths in the US in that year. And since 1980, 2 to 3 cases a year have been reported in the United States. We have done a very good job with this, a huge difference because of the vaccine. Tetanus, you guys have heard of lockjaw, okay? Tetanus is caused by a bacteria that is found everywhere. It's from dirt, it's from manure. It is universal in the environment. Gets into the body through a scratch, through a puncture, that kind of thing. It causes muscle spasms that result in the inability to eat and drink and can compromise the breathing. You can see this little guy is in a lot of pain too because it's quite painful. 11% of people who get tetanus die. And there's not a whole lot you can do about that once it happens. The vaccine is another toxoid vaccine. So again, we're not preventing the tetanus bacteria from getting into your body. That's not what the vaccine does. What it does is keeps that poison, that toxin, from causing the muscles to lock up. And this vaccine also was introduced in 1927, and then the combination that we currently use was introduced in the 1940s. So it's really quite well established. There have only been, there was a nice study looking at this done during World War II, so in the 1940s, and there were only 12 cases of tetanus, and half of those were in soldiers who hadn't been vaccinated, and those were documented among the US troops who were mostly routinely immunized, versus thousands of unimmunized enemy troops and civilians who died from tetanus-associated wounds during World War II. So that vaccination program among the military really made a difference for the soldiers serving during the Second World War. Before the mid-1940s, there were 500 to 600 cases of tetanus a year in the US. And in 1999, only 33 cases, so way, way down. And again, in unimmunized people. So pertussis, whooping cough, you guys have probably heard about. It's a bacterial infection. It is highly contagious. So being in the same room with someone who has this is enough to transmit it. It doesn't cause bad symptoms in older people. A little bit of cough, a little bit of cold symptoms. So older people can serve as a way of transmitting this to other people. And by older, I mean teenagers, adults. Infected kids develop a thick mucus in their windpipe, and they get these severe coughing spells that make it difficult for them to eat, drink, or breathe. And these coughing episodes will come and go over 2 to 3 weeks. And what will happen is the child will cough several times and then breathe in and go, which is the whoop, okay? It's most severe when it occurs early in life, so including babies, especially the really tiny ones, and it often results in hospitalization. This is from mid-2000, so probably 2005, the number of cases in various parts of the United States. So green is the places in the US where there have been relatively low numbers of cases of pertussis, 0 to 50, reported over the course of a year. In the blue is 51 to 100 cases annually. Maryland's at 92, so we're in the blue, but we're kind of getting close to that 101 case mark, but which would push us into the yellow. And then over 300 cases reported in these other countries. Now, you can see there are more cases, obviously, in places with higher populations. So, some of this is just to give you an idea that this disease is not gone by any stretch of the imagination. In 1926, the first pertussis vaccine was introduced. It was called a whole cell, so it was the whole pertussis bacteria, and it had some side effect problems. They did combine it with the diphtheria and tetanus vaccines to make the DTP. And for many of the older people, if anybody's in their 20s here, they probably might not have gotten this one. For anybody in their 25 and up, they got the DTP vaccine. So this is the one that many of us have gotten. In 1991, there was an acellular pertussis vaccine, meaning only a piece of the pertussis particle. And that one is the DTAP, and that actually has a lower side effect profile than the original DTP vaccine. Initially, it was introduced as a booster only. It was not given for the first set of shots. And in 1997, it was recommended for all the dosing. Now, it's beginning to look like this one may not have as long-lasting immunity as the original DTP. So there may be new recommendations about this one coming down the pike. We'll see what happens. In 2005, just so very recently, the adult tetanus shot had the pertussis added to it so that that reservoir could start to be eliminated, so that we would stop seeing pertussis in older people and have them not give it to the little people. The reason that was not done before is that DTP vaccine, that old one, this one, was really prone to side effects, especially in people over the age of 7. So we didn't recommend it, but the DTAP is really well tolerated, so that's been a good one. Measures of success, again, in the early 1940s, there were 175,000 US cases with 8,000 deaths from pertussis. And today, and literally this, there have been 7,000 cases since in the modern era, so since 2000, with only 10 deaths noted. So part of the death rate dropping is due to better medical care. We do have better inpatient care for that, but you can see a marked decrease in the number of cases of pertussis that we're seeing. And again, that's because here's pertussis and the rates of actual infection that are diagnosed. Vaccine was introduced here, and we have nothing. It goes away because we've been successful in decreasing the rate of infection. Here's another look at a similar one, but this one's not just the US, this is worldwide. So this is these are two measures of vaccine rates. So that as the vaccine increases, the rate of pertussis infection decreases, and that's worldwide. So it's not just here. And not all of these are places with good medical care. The vaccine side effects, and again, we're talking about the acellular pertussis now. We're talking about the current vaccine that we use. About half of children who get this will have no reaction to it. I mean, will just not have any problems with it at all. They get it, they're done. The other half of kids will get a mild reaction. It hurts at the site of injection. They may have a little fever, a little irritability. They may be off on their appetite. They get this when they're 2 months old for the first time. So, it's hard to know what bugged the baby. Some of it may just be sleep disruption and all of those things, but they get a little fussy. They can be a little off on their appetite, act a little tired. Some babies will spit up a little bit more, and you can get some swelling at the site. Those actually side effects, those mild ones, are even more common after the 4-year-old booster. So they're really very uncommon in babies. The babies do pretty well. About 1% of kids will have what we call moderate reactions, meaning a prolonged crying spell, a high fever. And that fever can lead to a seizure, although it's not because of the vaccine, it's the fever that triggered it. And the child can become limp, pale, and less alert. There is no long-term permanent damage to the child from that. Okay, that's important to know. It's scary when it happens. Obviously, you want to make sure your doctor knows that something happened, but it's not something that causes a long-term problem. In 3 children out of 10,000, you can get a more serious reaction, breathing problems, a shock reaction, brain inflammation. And that is a more significant issue. Long-term permanent damage from that has not been reported. But again, it's really frightening, and we don't risk it happening twice. So the 1 in 10, those 3 children out of the 10,000 who get this will not get another pertussis vaccine. We just won't do it. We have a diphtheria tetanus combination that doesn't cause this, and that's what we give to those kids if they've demonstrated a side effect that's a problem. These other side effects we don't worry about. H-flu, or Hib, you'll hear called, is a bacterial infection, can cause meningitis, which is inflammation of the brain and spinal cord. And that can lead to permanent blindness, deafness, mental retardation, and learning disabilities. It can cause epiglottitis, which is inflammation of the epiglottis, which is the top flap above your trachea, your breathing tube, which can lead to suffocation. And it can cause pneumonia. And the most common ages for this infection are 3 months to 3 years of age, with a peak at about 7 months. So older babies. In patients who get meningitis from this, the mortality, the death rate is about 5% if you get meningitis from this. The vaccine was actually introduced for children above 15 months of age. There was a first Hib vaccine that was done in 1985. The problem is you couldn't give it to kids younger than 15 months. It didn't work. So and you know our peak age of this is 7 months. So that's not going to hit the population we want it, right? It's not going to help them. So in 1990, they introduced something called the Hib conjugate, which was a vaccine that was effective for younger kids. And since then, before the introduction of the Hib conjugate vaccine, the number of cases of Hib disease was somewhere between 40 to 100 kids out of 100,000, less than 5. So it was a pretty common thing. And we were down to 1.3 because of the vaccine. And coming along for the ride, we also did a little number on otitis media. There was a little less ear infection action going on with this, although that wasn't the purpose of the vaccine. Happened to catch it. The vaccine side effect, 25% of children will have some pain, swelling, and redness at the site, but there's really nothing long-term. This is one of the most effective and one of the least side effect prone vaccines we have. It's a good one. Pneumococcus, you'll hear about, is strep pneumoniae. It has a bunch of names. This is a bacterial infection that causes bacteremia, meaning a bloodstream bacterial infection, along with sometimes shock, meningitis, and pneumonia. And it also, incidentally, is a big player for ear infections or otitis media. And the pictures here, just so you can see, this is an autopsy picture of a brain of somebody with pneumococcal meningitis. And what that white stuff is in the middle is pus from this bacteria. And then this is a picture of a child who's got this entire lung whited out because of a pneumonia from this organism. Okay. The incidence of the bacteremia is somewhere between 16 and 55,000 cases, so about 17,000 cases a year. About 1,400 cases a year of meningitis and about 71,000 cases a year of pneumonia. And the overall mortality for this particular organism was 5 to 7%. And it's higher in the very elderly people, actually, even than it is in kids. So in 1977, there was a vaccine for big people over age 2. And it's been recommended, continues to be recommended for elderly people and high-risk children over age 2. And the most common cited risk group for this would be people with sickle cell disease. Children with sickle cell have a problem with their spleen, and they're at very high risk for pneumonia with this particular bug, so we make sure that they get the one that covers more strains of pneumococcus. And it covers 23 different types of this bacteria. The one that we give to everybody only covers 13 strains, and that's okay. It works really nicely. For most kids, this covers the hot buttons, the ones that are going to cause the most problems. For the high-risk kids, they actually get both on the regular schedule, the recommended schedule. Side effects, mild reactions, again, soreness at the redness at the site, irritability, drowsiness. This one can cause a low-grade fever, and again, that seizure can be triggered by a fever again. And most of those seizures happening in about 1 in 10,000 children are mostly in kids who have a tendency to febrile seizures or have already had a seizure. They're kids who get seizures, so it's not a new reaction for most of them. With the pneumococcal vaccine that's designed for the older population, the 23-valent one, that one can cause a severe allergic reaction in about 1 in 10,000 people. That's not very common. And so it's just something to watch for. It's like any other allergic reaction. Talking about polio, and I know I'm flying through this stuff. I know you guys are going to get a chance to ask questions, I promise. Polio is a gastrointestinal virus, meaning it's spread the same way a stomach virus is, okay? Gets on someone's hands because they pooped it out, and then it gets spread to other people by hand washing and then ingesting it. About 95% of people who get the virus from polio don't have any symptoms. They're fine. Okay. Problem is with everybody else. So 1 to 2% will get some stiffness in their neck, back, and legs. Less than 1% of people with polio will get a paralysis, which includes the respiratory muscles. And what this picture down here is from the polio epidemics in the 1950s. They didn't have ventilators back then, like we do. So they had these things called iron lungs, which is where you slide the person inside of it and it breathes for them by pushing on their chest from the outside. And what would happen is some people recovered with this. Some people never did and lived out the rest of their lives in an iron lung. Okay. Nowadays, they would live out the rest of their lives vented probably with a trach, and it wouldn't be very pleasant either, but we have different technology now. For the people who don't recover but can still breathe on their own, and this is actually a recent picture from, I'm not sure where in the developing world this was taken, but this is a young boy who got polio and was left with muscle weakness in his legs, and as you can see how skinny his little legs are, that's not malnutrition. Look at his nice chubby cheeks, right? This is a little guy whose muscle mass is gone because the nerves to his legs just don't work. So he's walking around with the use of crutches, and this is going to be lifelong. Okay, he's not going to get over this. This is done and could have been prevented by a vaccine. The Salk vaccine, which was the injected polio vaccine, which is actually the one we use now, was introduced in 1955 in the United States. And I don't know if you guys know who this guy is. That's Elvis Presley. This was from a press release done then trying to encourage people to get the vaccine. So Elvis did a shot for the press. The Sabin vaccine, which was the oral one, was introduced in '62 and replaced the Salk vaccine. The Sabin one, the oral drops that some of you may remember getting when you were a kid, was a live virus vaccine. And so there were some issues with that, which I'll talk about. In 1979, the last case of polio that was acquired by somebody from the world rather than from vaccines was eradicated. So we haven't seen real, live, honest to goodness polio in the US for a very, very long time. But because of that, the risk of getting what's called vaccine-acquired polio from the live vaccine became a problem. Because when you're not seeing polio, you don't want to have a vaccine that's going to cause one in, it's a 1 in 10 million. It's not very common. But you don't want to have that when you have an alternative that doesn't do that. So we switched over to an injectable only. Doesn't work quite as well when you have an epidemic going on, but in our setting in the United States, it's quite effective in keeping polio from becoming a problem again. And so this is what I was talking about, which is the live polio vaccine. It's given orally. The advantage is it's really easy to give. The kids don't mind. It tastes like sugar. They're very happy with it. It gives you what's called IgA, which is a local antibody in your gut. So it fights before the natural poliovirus even has a chance to get inside. It's already attacking it and keeping it out of your body. So that works really, really well. And because it's a live virus, it's actually pooped out. The vaccine is pooped out from the people who are receiving it. So they can actually spread the immunization to other people who didn't get the drops and share it, which is kind of cool. So in places where you have trouble getting vaccines out to a whole population, what a great tool that is. Give it to the kid, hope he takes it back to his village. What a wonderful thing that is. So there were some advantages. The problem is that vaccine-acquired paralytic polio, not a good thing, okay? And so we moved away from it. The killed vaccine that we use now, the injected, almost no side effects. Some people are a little bit sore at the site, occasional allergic reactions, but it's really pretty harmless. And so that's a nice thing. Measures of success. This is 1988. The countries that have eliminated polio are in pink. I'm sorry, have never eliminated polio are in pink. The ones that have are in white. So the US, nicely over here, where we haven't had polio in forever, like I mentioned. This is the part of the world that hasn't gotten rid of it in '88. Here's where we are today. Okay, this is all vaccination. And we're using the oral vaccine to a large extent in the rest of the world because of that epidemic problem. Now, there are a couple places you'll see here. That's Pakistan. There's some places down in Africa. And we're starting to see an increase in places like Afghanistan, like Iraq, Syria now, where war has made it very hard for vaccination programs to get out to people. And we're starting to see an uptick in polio cases in those places. So we haven't really, so places that had eradicated it are starting to see it again as vaccinations have dropped. So we know that we don't have a permanent fix here. The World Health Organization was hoping to have eradicated polio worldwide by 2010. Clearly, we've got a ways to go. But here's the worldwide incidence, which you can see again, vaccination, polio. So. Rotavirus, this is one of our newer ones. Many of you have probably experienced this either as parents, daycare providers, nurses, or yourself, unfortunately. Rotavirus is your classic stomach virus. Causes vomiting and watery diarrhea for 3 to 8 days, some crampy abdominal pain and fever. This is a picture of a baby who's gotten severely dehydrated. It's hard to see on this slide, but this is called tenting, which is when they get so dehydrated that their skin, when you pinch it, just stays up instead of popping back. And that's really bad. About 55,000 children a year are hospitalized in the United States with rotavirus, and it accounts for about 600,000 deaths per year of children worldwide from dehydration. Okay, and so it's a big player. We don't think about it as being that scary here, but it really is. We're using a second generation, so it's a second version of a rotavirus vaccine now. It's live and attenuated, so again, it's that weakened virus. It has a really strict administration schedule, so if you lapse on this one, there's no catching up. So you get it on schedule or you don't get it. Right? It prevents about 74% of all rotavirus cases, so it works to prevent about 3/4 of cases of the disease, but it's really good at preventing the very severe types, so 98%. So we can really cut down on the severe hospitalized generating one. And we've had a decrease, 96% decrease in hospitalizations due to rotavirus since the introduction of this in the United States. So that's been a big player for us. Measles. This one, we're gonna get back to the measles because I know that's a hot topic for a lot of people. Let me give you the reasons why we care as healthcare providers about this particular bug, okay? Measles is a highly contagious upper respiratory virus. If I had measles right now, Kevin would be at risk if he hadn't been vaccinated from being in this room with me, okay? It is extremely contagious. It is airborne, it can be coughed and shared with other people. It causes cough, runny nose, and conjunctivitis, which, pink eye, which is not huge, that's not a big deal, and the famous rash, which is that. The complications are where we run into problems. 5% of people with measles get pneumonia, 0.1%, so 1 in 1,000 people will get measles encephalitis, which is inflammation of the brain. Somewhere between 1 and 3 people in 1,000 will die from measles, okay? And there's a chronic long-term infection called subacute sclerosing panencephalitis, what we call SSPE, that is a persistent brain infection with measles. It occurs 7 to 11 times out of 100,000 infections, and it is permanent, cannot be cured, and eventually will kill the child. And you'd like to think that you'd never see this. I haven't seen it since I was in training, but I saw a case when I was in training as a resident, which was in the late 80s, early 90s. So it's not gone. It's something that's still out there. They're definitely seeing it in other countries, even now. The measles vaccine that we use was introduced in 1963. It's live and attenuated, so it's that weakened measles virus. It's given under the skin as part of a combination with measles, mumps, rubella, so it's the MMR that you've heard about. 80% of people have no side effects from this vaccine, 80% of kids. About 5 to 15% will get fever. Usually it starts a week to a week and a half out after the vaccine. And again, 3 out of 1,000 kids may get a fever, or a febrile seizure with it. But again, not the vaccine causing it. It's because they got the fever that they got the seizure, okay? 15% of women, for reasons we don't understand, will have a little bit of joint pain from this one. It's not clear, but it's transient, meaning it comes, it goes, and it's done. It's not a long-term problem. 1 in 10,000 a severe allergic reaction, and then 1 in a million people from the vaccine will actually get brain inflammation from the vaccine, okay? Doesn't cause permanent problems. So no permanent sequelae from that. And I'm about to lose the battery on my pointer, so. The vaccine was licensed in, again, like I said, in the 60s. This is the cases of measles in the thousands, okay? So at the peak of the measles epidemic, it was 800,000 measles cases per year, okay? And as the vaccine was licensed, there was a little drop off here, so that was as bad as it got. And then all of a sudden, vaccine, boom. And here's where we were, okay? And I'll explain why we're in a little bit, because we're having a problem now. So it's really effective. Mumps. Virus is spread by sneezing and coughing. Causes swelling and tenderness of those salivary glands, so the glands under the neck that produce your spit. You can see the swelling on this poor little guy. The complications, the one that we are the most concerned about is what's called orchitis. Guys, that's inflammation of the testicles, okay? 20 to 50% of boys over the age of puberty will have this complication from mumps, and it can lead to sterility. Okay, so what can happen is that the 12-year-old who got mumps may not be able to have kids. That's kind of a lot to get from mumps. Aseptic meningitis, meaning not the bacterial type, about 15% of patients will get that. Inflammation of the pancreas, inflammation of the ovaries in women, again, less common. Interestingly, it can cause 1 in 2,000 cases you can get permanent deafness from mumps. It's a more consequential effect of this infection, not as common as the other complications. The vaccine itself was approved in 1967. It was a strain from the developer's daughter who had mumps, and he used her serum to create it. There are actually no known side effects of the mumps part of the vaccine. So all the side effects of the measles, mumps, rubella, the MMR are from the measles part. Pre-vaccination, we had about 200,000 cases a year in the United States with 20 to 30 deaths annually. In 1998, there were 600 reported cases of mumps and no deaths in the US. So again, doing better. Okay. Rubella, German measles, spread from droplets into the environment, really mild illness for most people. Low-grade fever, swollen glands, swollen lymph nodes, and a rash. Looks a little bit like measles, but not as severe. Get some joint pain, a little bit of drop in the platelets, which are the part of your blood that causes your blood to clot, but not a huge problem. A little bit of inflammation of the brain can happen. Arthritis that is temporary and can happen in women and teenagers. The reason we worry about rubella is not because of rubella. I need to wrap it up, I know. 5 minutes, okay, we're gonna move faster then. So rubella, there's this thing called congenital rubella syndrome, which is what happens when rubella infects a woman who's not protected, who's pregnant. And what it can cause is cataracts, blindness, mental retardation, and defects in the baby. So this is something we're trying to prevent. And we're seeing this in other places. So rubella side effects pretty much non-existent from the vaccine. And again, in 63, 64, there was a 12 million person outbreak. There were 11,000 deaths, fetal deaths, 20,000 cases of congenital rubella. We've had less than 10 cases per year in the US since the introduction of the vaccine of the congenital rubella syndrome. Worldwide in 1999, 11,000 cases of congenital rubella because the vaccines haven't penetrated into the rest of the world as well. Chickenpox, is going to go really quickly through this. Many of the people in this room have had chickenpox. Some of you have not. It's very contagious. Most people think of chickenpox as being this little guy, right? He's happy, he's smiling, he's got some pox, he doesn't care. This is what we're worried about, okay? Which is a secondary bacterial infection caused because the kid's skin was broken and he was itching, okay? You can get bacterial infections, you can get chickenpox inflammation of the brain, 1 in 10,000, pneumonia, 1 in 10,000. It's fatal in less than 1 in 10,000 cases, but can cause some very severe problems. So this is what we're worried about, is this poor little guy down here. The Varicella vaccine was licensed in Asia in 1988, in the US in 95. It's live, so we don't give it to immunocompromised patients because we actually have some treatments that are extremely expensive but very effective in preventing chickenpox to someone who's exposed, who's immunosuppressed. It is 100% effective, this vaccine, in preventing the severe type of chickenpox. It doesn't prevent all the cases, 75%. You know, it protects against regular chickenpox, and actually all 3 of my children got chickenpox during their school outbreaks, even though they had been fully vaccinated. But they were sick, they got 2 bumps, they were back in school in 2 days, no big deal, no harm, no foul, it was easy. And that's typical. Hep A, another one of these gastrointestinal ones that spread from stool and bloodstream. Maryland actually was one of the earliest places to get the vaccine for this because it's a shellfish and seafood thing also, and we have lots of shellfish and seafood, so while you're enjoying that Old Bay, make sure that you're careful about where it came from with your crabs, because this is, you know, where you get that. It causes fever, weakness, nausea, abdominal pain, dark urine, and jaundice, and here's a guy who has acute hepatitis A. You can see how yellow his eyes are. It can cause some deaths, and in 125 to 200,000 US cases per year, there are about 70 to 100 deaths per year from hepatitis A acute infections. So here's the map. The high prevalence is in dark green, low prevalence is in white, so we're doing a good job here in the US. Obviously other places in the world not so good. the introductions, again, side effects of the vaccine, it was added to the regular recommendation schedule in 2005 for everybody. It was actually introduced in '99 in Baltimore City because of our high population. And it's really mild side effects, some soreness at the site, that kind of thing. And here's the hepatitis A reaction. Here's the infections, vaccine introduced, boom, works. Neisseria, it's another bacterial infection, causes meningitis, bloodstream infections, and because of the effects on circulation, you can start to have loss of extremities, infections that spread very rapidly. Within 24 hours, it can kill you. This one's scary, gets us very frightened. 10 to 14% of people who get this die. Okay, 11 to 19% end up with permanent neurologic problems if they survive it. Vaccines have been introduced for that, and they've been around for a while. It's one of the more recent ones, 2008. It was actually approved for high-risk kids, those sickle cell patients and some of the other kids down as young as age 2. It's recommended for all of the 11-year-olds and up, and there are 2 shots given. Okay. I know I need to wrap this up. I knew I was going to run out of time. So we're going to skip through this. HPV, I know you guys are going to have questions about, so I'm sure I'm going to get questions about this one when we get to it. But HPV is the first vaccine that was designed for the purpose of preventing a type of cancer. Human papillomavirus is incredibly common. About 15% of the population have HPV infection, and there are strains of this that cause cervical cancer, which looks like that. That's the opening of the uterus. It's actually a view inside of a woman's body during an exam, and that's what the cancer looks like. And the vaccine is designed to protect against that. It's 100% effective. It only protects against 4 strains of the virus, which are the ones that are the most common. For those strains, it's 100% effective in preventing cancers caused by those strains. Doesn't protect against the other 150 that could cause it. So it's not going to be 100% on this one, but it's pretty good. And we're now doing the boys too, because girls are getting it from somebody. So got to do that. Side effects. It's actually kind of uncomfortable to get this one, and some people faint. So that's something, if someone has a history of fainting, we like to keep them in the office and watch them after they get this one to make sure they don't do that. But it's not dangerous. And there's a neurologic complication called Guillain-Barré syndrome that has been associated with this. Not entirely sure whether that's really is caused by the vaccine or not, but that's under investigation. It's not very common. The flu. Reason we're worried about it, pneumonia, myocarditis, which is inflammation of the heart muscle, lots of hospitalizations, lots of deaths caused by influenza. The injected flu vaccine, side effects are mild. You can get some flu-like symptoms with fever, soreness at the site, some chills, body aches. It can't give you pneumonia, encephalitis, myocarditis. It can't do the bad stuff the flu can do. It can make you feel a little yucky. So keep in mind, you cannot get the flu from a flu shot. Okay, it's really, I can't emphasize that enough. Okay, there is a flu mist, which is the spray that is live. It causes a cold if it's working. It should give the kid a cold or the adult. Okay, we don't give that to anybody who has any chronic medical problems, asthma, things like that. It does cause cold symptoms, but it's incredibly effective at preventing the flu. Recommendations are universal. Everybody should get a flu shot over the age of 6 months. The effectiveness depends on the match between the strain that's out a given year and the vaccine, and we've run out of time to talk about it. Other vaccines, definitely not going to talk about these, but they exist. Here are the combinations that we have. So we don't give all these as single shots. That would be mean, because then you really are in a pincushion. Someday we'll have this, which is everything in one. I want to license the name Panimmune. I think it would be really good. Historical vaccine problems, RSV vaccine, respiratory syncytial virus causes bronchiolitis, bad breathing problems in very young babies. They did try to introduce a vaccine for this. It made the babies sicker, so they stopped it. So we do have a history of stopping vaccines that cause problems. There was a vaccine against a strain of swine flu in the 70s, and there was a Guillain-Barré syndrome problem with that particular vaccine, so they pulled it. They recalled it and stopped giving that one, but that problem has been fixed and has not recurred. Rotavirus, the original rotavirus vaccine, caused some problems with something called intussusception, and so they pulled that one, and that's why we have the second generation one now, which does not cause that problem. There is a single measles vaccine that isn't lifelong protective, but can be given to 6-month-olds in case of an outbreak. The problem is up until 6 months, you have a very vulnerable population that could get the measles, and the idea is to give passive immunity by protecting the mothers to make sure that you get a kind of boost in your immunity before. So there is some discussion. Because it's a live virus vaccine, they're looking at the safety of giving that to a pregnant woman, and that's sort of where the discussion is happening right now. So jury's still out, but they're definitely moving in that direction with the prevalence of measles recurring. The reason this is an issue, and I'm not going to spend a lot of time on it, there was a very unethical doctor in England who fraudulently created a study because he had stock. He owned part of a company that made a measles vaccine that was just a measles vaccine. So he decided to prove that measles, mumps, rubella vaccine caused a problem so that everyone would stop doing that and do his vaccine instead. And he managed to get a very reputable medical journal called The Lancet to publish this study. Word got out, autism and MMR are attached to each other, and all of a sudden everybody freaked out. Okay, now, turns out he lied. His data was fraudulent, his research methods were questionable. It's all nonsense. And every single study that has looked at this since then, and now we're talking 1998, so we're now 16 years out from this, every single study has demonstrated there is no relationship between autism and the MMR vaccine. None, zero, okay? However, we can't get this horse out of the barn. So there are a lot of people back in the barn. So what's happened is a lot of people are like, I'm not giving an MMR, I'm not vaccinating my kids, forget it. And what's happening is we're starting to see measles come back. And that's a problem. There's a ton of bad information out there, and that's the problem, is when you go do a web search, you don't know whether you're getting a reputable site or one that's a problem. There's a handout that I have there which has good information about vaccines for you guys, including some information about those sorts of things. But it's really, you're right, getting out the public information. The problem is it's really hard to convince something once they've decided that that's true. It's really hard to fight that. The people who are opposed to vaccines in general, not just the MMR, these are the questions that have been raised by people who have concerns about vaccinating their kids. And I bring them up here because I want to address those really quickly, and I know I'm over. Too many antigens. So as I said, an antigen is something that causes your immune system to respond. That's one thing. Are we hitting these kids with too many of these? Is it overwhelming them to have all these shots? That's a question that a lot of parents have raised and are asking for alternative vaccine schedules, giving them separately, not putting all of these things in one, all of that kind of thing. The false beliefs about side effects, like the autism thing that we just mentioned briefly, and then these diseases are gone, so why do I need to put my child at risk? Well, I think I've proven to you these diseases aren't gone. Okay, so that one at least we know are not there. The 11 vaccines that we recommend have fewer than 130 total proteins in them. I pulled this statistical analysis, and I can provide the reference for anybody who wanted to. An estimate by age 6, living in the world, just walking around, a child is exposed to more than 3 million new antigen exposures by the time they're 6. So these 130, that's a drop in the bucket. We're worried about 130 when they're getting 3 million. Come on, really? So that argument really doesn't hold up. And the American Academy of Pediatrics, that sets guidelines for vaccinations for kids, along with the Centers for Disease Control, has done studies on this and looks at those alternative vaccine schedules. And what happens is the kids get sick with the things we're trying to prevent because they didn't get the vaccine on time. So it's not helping us to prevent a lot of these illnesses to give an alternative schedule. So we really are pushing to do things on schedule, on time. It's just extremely important. She was asking, one of the concerns that this lady has about vaccinations is that she doesn't know what is actually in the vaccine and doesn't want to give her child something when she doesn't know what's in it. And that's a very legitimate concern. As a parent, that's exactly what we want you to do, is think about everything your child may be exposed to. And there is very good information. There is information on the Centers for Disease Control website. And the handout has a listing of a lot of good places for vaccine information. There are vaccine information statements, and then actually the package inserts for every single one of these vaccines is actually available publicly and online. So you can actually look, and if you have questions about it, you can ask your doctor or your child's doctor to explain what they are. There have been concerns raised about the preservatives in the vaccines. We don't use the mercury-containing preservative for anything in the United States that is given to children now. Certainly, that's been a concern, although, again, that hasn't been proven to be a problem. We decided, rather, as a country, we're just not going to do that, and it's gone because it was causing so much concern. So it's a good question, and the information is definitely out there. The egg allergy thing is actually a really wonderful question. So she asked if there were any alternatives to the vaccines that are produced in egg products, and that includes things like MMR and varicella and flu. For people who are allergic to eggs. And what's interesting is that the recommendations have actually changed on this. Because of the risk of these illnesses and the fact that the amount of egg in these vaccines is tiny, 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 unless you are a child or adult who is on the strictest egg allergy restrictions anybody has ever seen, you can get the vaccine. They do recommend that you are observed in your doctor's office for a period of time afterwards in case you have an allergic reaction so that you can get epinephrine and Benadryl and be treated, but it's very, very rare. So you would have to have who eats no baked products that were produced anywhere but at home, okay? Nothing that has mayonnaise, nothing that, and when you start asking people how restrictive they are with their egg allergies, it's pretty rare to have anybody. I have about, our practice, I think we have somewhere around 13,000 patients, of whom 700 or 800 of them are mine. I have one patient in my personal panel who has a severe enough egg allergy that we've had to adjust his vaccines. And you don't give them. They are part of that small group of unvaccinatable kids that you have to protect everybody else to keep them from getting sick. Because there is a population of people who cannot get vaccines. This is the "aren't the diseases gone" slide, and the answer is no, they're not gone. Lots of examples of badness happening recently. And the measles one is a big one because of all of the cutting back, because of that false study in Europe. Measles has really taken an uptick. And we're starting to see it in the US too. Risk benefits, so whenever I talk to my patients who have concerns about vaccines, I will be perfectly honest with them. Nothing we ever do in this world is without a risk. The issue is the benefit of what we're doing more important than the risk of doing it? And so when you look at the vaccines, the risk of the vaccine is that 1 million encephalitis thing versus this for the MMR. The DTaP, there's the risk of the vaccine, there's the risk of the actual infection. It's a no-brainer from that point of view. The risk-benefit clearly comes down on the favor of vaccinating, and it's just one of those things. But if a parent has concerns, it's a legitimate concern to ask about what's better for your child. A mom out there in the community, out there in the world, once said this, Susan Walther said, "I don't want my child to be the 1 in 3 million children who suffers a potentially fatal reaction to a vaccine, but I also don't want mine to be the 1 in 10 that dies if they get it." And that pretty much captures the risk-benefit argument pretty concisely. Something to consider, and I came across this while I was researching this talk, and I am going to share this. People worry about these side effects from vaccines. How many kids are involved in football, basketball, soccer, sports, okay? 12 deaths a year in the United States playing football among kids 2 to 18 years old. 28% of kids ages 5 to 14 are injured playing football, okay? Basketball, 15% of kids are injured, deaths 6 a year in the United States from playing soccer, okay? Those are actually way higher than the rates of any of this stuff happening from vaccines, but you're not seeing the kids being pulled off the soccer field, right? I'm not saying kids shouldn't play soccer. They should. They should get out there. They should play soccer. But understand, we're talking about very, very, very small risks. And we put ourselves at risk driving with the cell phones and the texting and all that stuff way more than anything we do with these vaccines. And that's just something to keep in mind, that when you're making choices about safety and about keeping your family safe, vaccines are relatively low risk compared to some other things that are normal parts of our lives. I'm going to skip this, although this talks about the unprotected kids. So this is Ben, who's immunosuppressed. So like our egg allergy child or a child with severe HIV disease or a kid on chemotherapy, he can't be vaccinated, but because everybody around him is protected, he's not going to get sick, okay? We have an obligation to the other people we share this world with. And that's what that kind of gets to. And the idea is that somebody who can carry it but not be sick can give it to someone who's susceptible, who can't get immunized. And it keeps going and going and going and getting all those people, as opposed to the transmitting person hitting someone who's protected by a vaccine. It won't spread anymore. So that's something we call herd immunity, and it's really, really important. And for measles, we need 90%. We need 85 to 90% of the population protected to keep it from spreading. And there are places in the US where it's below that now. Again, because of misinformation. So here's the information. You have this on your handout. And the references for this talk I can give you guys separately. I didn't give you those, but if you want them, I can certainly share them.